Hello dear students, let's quickly look at how we are going to manage pneumothorax. First thing that you need to know is whether it's a traumatic pneumothorax or whether it's a spontaneous pneumothorax. In traumatic, two things, whether it's tension pneumothorax or an open pneumothorax. In tension pneumothorax, the first and the immediate intervention that has to be done is a needle thoracocentesis. In adults, we do it in the fifth intercostal space in the mid-axillary line. In children, we do it in the second intercostal space in the mid-clavicular line. And following this, you're going to insert a ICD. Now, if it's an open pneumothorax, along with the ICD insertion, you have to use the three-sided occlusive plaster dressing. And if there is an associated flail chest, the patient might also need mechanical ventilation. Now moving on to spontaneous pneumothorax. This can either be primary or a secondary spontaneous pneumothorax. Now the size of the pneumothorax to be taken into consideration is 2 centimeters. So in primary pneumothorax, if the size is less than 2 centimeters, nothing has to be done. You're just going to observe it. If it's more than 2 centimeters, you're going to put in a needle and aspirate it. Whereas if it's a secondary pneumothorax, if the size is less than 2 centimeters, needle and aspiration. If it's more than 2 centimeters, patient needs a ICD insertion in the safety triangle. Now, even after all of this, if there is continuous air leak or if the patient has a recurrent pneumothorax, that means this patient is a candidate for surgical intervention and you have to rectify the problem which is causing the pneumothorax. Thank you.